may or may not know, stands for Asia Pacific Malaria Elimination Network, and it's a network, a clustering of 22 countries across Asia Pacific that share the common objective of achieving malaria elimination by 2030. And APMEN as an organization has the mandate to support and assist those 22 member countries to achieve malaria elimination, and it does so in multiple different ways: capacity building, support for policy development, knowledge sharing, and this webinar is one example of that knowledge sharing. So from Amita, welcome to everyone. My name is Leo, by the way, Leo Braack, just in case you want to put the name to the face. So we've introduced APMEN. I'd like to introduce our panel of speakers to you, and then I'm going to, after that, get into just a brief overview of how this webinar is structured, how it's going to unfold. So with us, Rupam and Jeffrey, if you wouldn't mind putting your videos on. So we have Dr. Bill Hawley, who's chief of the Entomology Branch in the Division of Parasitic Diseases and Malaria at the Centers for Disease Control and Prevention in Atlanta, Georgia. Bill is going to be our first presenter, followed up by Dr. Jeffrey He, who's a former WHO malaria scientist. He also worked with Malaria Consortium for a few years, where he was also the technical lead for the APMEN Vector Control Working Group. Thank you both, Bill and Jeffrey, and then also thank you to Professor Indra Vythilingam, who's professor in the Department of Parasitology, University of Malaya in Kuala Lumpur. Thank you for your commitment and time to be with us, Indra. And then finally, warm word of welcome also, and thanks to Dr. Rupam Tripura, who is a researcher at the Mahidol-Oxford Tropical Medicine Research Unit, MORU, at Mahidol University in Bangkok. So to all of you, sincere thanks. Okay, I'm doing a lot of talking. I'm going to try and cut it short, but we need to explain to you how this is all going to work. I'll be brief. So the four presenters are going to talk back to back, roughly 10 minutes each, and then we'll have a collective questions and answer session after those presentations. So for members of the audience, and I apologize in advance for this non-participative medium, it's just the nature of the webinar platform we use, that because of bandwidth restrictions, it's not possible to have everybody on video and able to talk, which would have been the ideal, so it's properly interactive, but it's just not possible. So, but at least you can pose questions. At the bottom of your screen, there should be a Q&A little icon, and you can press that, and then you can raise questions as they come to you during the different presentations. Now, please concentrate on this. Our other members of the audience, when you see a question pop up on the right-hand side of your screen, you have the choice, if you like that question and you would like to support that question, somewhere embedded in that Q&A option, there's a raise your hand or support flag, which if you click on that, it has the effect of bumping up the importance of that question. You know, I mean, during the course of the presentations, if people present questions, they're just going to go from 1 to 100 or whatever, one after the other. But if people click in support of a particular question, it raises, it goes up the hierarchy, and the more prompts or supports or upvoting it gets, the higher it goes. And that is going to guide me at the end in the Q&A session as to which questions should be prioritized and directed towards our panel. So please, audience, use that Q&A button, ask questions, and upvote them as you see fit. So also, unfortunately, as I said, our members of the audience, everyone is muted. There's no video. Only our panelists will be able to join us visually and by audio. Take note that the webinar is being recorded and it will be placed on our APMEN Aurine platform in a couple of days' time after a little bit of editing and so on. So it will be, you can refer colleagues and so on to the webinar if you enjoyed it, if you think it's worth sharing with colleagues. It will be available for looking at afterwards. I will at the end, towards the end of the Q&A session, I will put up on screen the websites so you can write it down for use if you want. Okay, enough talking now from my side. I'm going to ask Dr. Bill Hawley, who's our first speaker, if he can share screen and get his talk ready for presentation, and then just dive in, Bill, with your presentation. Dr. Hawley is going to talk about diverse challenges and solutions for elimination of residual malaria transmission in Southeast Asia. Bill, if you have problems and challenges, just feel free to voice them and we'll try and assist and help.
Okay, I'm getting a message. Thank you, Leo. I'm getting a message that I cannot start screen sharing while the other participant is sharing. So you have to stop.
Okay, that's me. I apologize. It shows my lack of...
Oh, it's all new to all of us. My goodness. So
maybe I've stopped sharing, so you should be able to now. Yeah.
Okay. Now let me proceed.
There we go. Excellent. Thank you, Bill.
Let me get this. Uh-oh. I don't need that. Okay, I want to click this. Okay, good. All right. Well, thank you, Leo, for organizing this, and thanks all of you for getting up early or staying late or whatever the time is for participating in this. I am going to talk about challenges and solutions for elimination of residual malaria transmission in Southeast Asia. Like everybody, I'm going to talk about countries where I have experience, and I'm aware, I'm looking, there are a lot of people from India, and I don't know to what extent these conclusions and generalizations are relevant to India, but most of what I'm going to talk about is based on field observations in Myanmar and Indonesia. Both countries I've worked in for a while and have a fair amount of field experience. At the start, I would like to express my gratitude to the Ministries of Health of both Myanmar and Indonesia for putting up with me, for allowing me to visit a lot of different malaria endemic sites in both of their countries. In the case of Indonesia, over a period of 15 years, in Myanmar over a period of about 5 years. So I just want to note that both ministries have been very kind and open and cooperative in allowing me to visit a large number of sites in their country. So thank you. Okay, there, in my view, at least in the experience that I've had in Southeast Asia, there are 4 types of residual transmission. We talk a lot in the Mekong about migratory forest goers of various types, sometimes ethnic minorities. But also, and we'll see briefly in Indonesia, at least in parts of Malaysia, there are people who live in the forest. There are indigenous people who live in the forest and migrate in and out of the forest. They may live in the forest and they may move out of the forest to sell forest products. So there are indigenous people who actually live in the forest who were exposed to malaria. There are also village-based people who perform seasonal work in farm huts. They're based in a village and they spend various lengths of time commuting to farm huts in areas where malaria risk may be higher. And then I think sometimes in countries in Southeast Asia, outside of Indonesia, at least, there are people living in the lowlands where Anopheles peraltae species are common, where it's really a different ball game in terms of malaria control. And I'll end this talk talking about that area. So it's kind of a truism that as malaria transmission has declined in Southeast Asia, the sites become harder to reach. And we'll see, I'll show you a few pictures of hard to reach sites in Indonesia. Some sites, farm huts, are reasonably accessible via village bureaucracy. Some sites are really unreachable, and I'll show you a picture of a representative of one of these sites. So here we go. Here's West Kalimantan. You got to go upriver in a boat. I'm going up to where Jeffrey and Indra are coming from, but from the Indonesian side. It's kind of hard to reach, but it's not that bad. But then on the way to the boat, you see a young lady. This is an indigenous forest dweller, a Dayak, who has migrated out of the forest into town to sell her durians. So it's an example of migration from forest to town, which we don't often think about, but it's not uncommon, at least in Kalimantan and also in parts of Sumatra in Indonesia. Here's another hard to reach site. This is Isra Wahid, professor at Universitas Hasanuddin in Makassar, going up the road on a mining motorcycle to get to a mining site in the Meratus Mountains in Kalimantan. Now, this young lady in Myanmar, in Rakhine, is an example of a socially hard to reach site. She's getting a bed net because this group of folks was reported to have experienced several cases of malaria, and the President's Malaria Initiative provided them with bed nets. In conversation with this lady through a translator, I can't speak, in her case, she was speaking Rakhine dialect. Her husband is a teak cutter, goes to the forest, spends a couple of weeks at a time cutting teak, comes back, and he's infected with malaria, brings it back to his village. And we quizzed and tried to find out where this guy was going to cut teak, and there is no way this village was going to tell us where they were cutting teak because the activity is hard-line illegal, and they also want to protect their site. So some sites are inaccessible not because of geography, but because of social issues. Here's a farm hut, also in Myanmar, in Rakhine, where people are sleeping by the river. There's an Anopheles minimus there. They're there sometimes they're not. It's about an hour and a half walk from the village. And the public health bureaucracy can access that site via the routine bureaucracy that is generally, in most countries, aimed at sedentary agriculturalists. There are other sorts of economic activity that lead to malaria risk. This is also in Myanmar, Rakhine, where we ran across people who were brick makers who came certain times of the year, depending on rainfall, to make bricks. They were there for 3 months. They're sleeping outside by the river. They're at risk for malaria, and there were cases. Okay. Another type of activity that's important are gold mines. There are gold mines throughout Southeast Asia. There are various levels of organization and legality. Each requires a customized approach for control. In Aceh, where I worked a fair amount with the Ministry of Health, provincial intervention was needed. In Gorontalo, which is in North Sulawesi, in fact, it was the health center that was able to effect control. And in the Meratus Mountains in Kalimantan, it turned out that those sites were reasonably well organized, and the central government, through intervention to local government, was able to effect control. Here's some gold. I don't know if you all have been to gold mining sites, but gold is a hard business looking for it, and also to purify it requires use of mercury and sometimes cyanide. So it's associated with various environmental risks as well. So here's an example of one large mine. The mines can be big. Buru, which is in eastern Indonesia. There are about 40,000 people. The population of this island was 160,000 people. There was a gold rush there with about 40,000 people coming in all at once from all over the archipelago, mining for gold. Then they pretty much left and went home. And so this was a huge challenge for the local government in Buru. In Gorontalo, on the other hand, you saw something really dissimilar, artisanal mines run by local people. So the people running these mines were local folks. They're from Gorontalo. They're small-scale operations, and it turned out that one of the nurses, this is a nurse, is a guy, a big fella, who worked as a nurse at one of the health clinics. He was a part-time gold miner, so he knew the networks of gold miners, and at least in the area of his health clinic, he was able to map out and provide services, nets, and diagnosis and treatment to the miners. He knew the network. This is the drums that people break up the ore and amalgamate it with mercury for purification of the gold. Okay. In Aceh, on the other hand, there were artisanal mines as well, but the social structure is different, and the social structure matters. On the left is a guy who's from West Java, from Tasik Malaya. He's imported labor, whereas on the right is a young man who is from Aceh, who has put his stake, he's the stakeholder, and he's importing labor to mine for gold, and he's using labor from West Java that comes and goes. They dig holes straight down underground and then dig parallel to the surface underground, looking for ore, bringing it up, and sometimes, as you note in this part of Sumatra, if you have a failed mine, it fills up with water, and guess what you got? A nice breeding site for Anopheles ballavicensis, which is a good vector, by the way, and I'm just noting this. This is a plug for Dr. Indra Vythilingam's talk. In Sabang, in Aceh, the local authorities eliminated malaria, but lo and behold, they had an outbreak, and it turned out after molecular analysis to be Plasmodium knowlesi. So how you deal with that and how you document that you have eliminated human malaria is a hard thing in forested areas of Southeast Asia, because you've got to be able to know when you've gotten rid of vivax and falciparum, and what you may be left with is residual knowlesi Plasmodium. And this is Dr. Erna, who was the head of malaria control for Sabang in Aceh, and if anybody can get rid of knowlesi, it's her. So now I'm going to end this somewhere east of Wallace's line. You guys know about Alfred Russel Wallace, who was in Bali, and then he crossed over to Lombok. He noticed a difference in the bird population, and he observed that the flora and fauna east of Bali in the Indonesian archipelago were substantially different from those on the western side. East of Wallace's line, somewhere east of Wallace's line, there's a transition from the Asiatic mosquito vectors to the Papuan and Australian vectors, which include the Anopheles ferralti complex. Some members of this species complex are highly anthropophilic, and they are better malaria vectors than the usual characters that we have in Asia and the Mekong. In some parts of this area, LLINs plus case management are insufficient to dramatically reduce malaria transmission. You still end up with API in the hundreds in some areas with good coverage of both. So you need other interventions, including larval source management, which can be appropriate for some of these vectors, and borrowing from the Mekong region, village malaria workers to put pressure on the formation of gibmidocytes. So you're preventing transmission from humans to mosquitoes. So this is just showing you where Wallace's line is. After I looked at this, I noted that they drew the line wrong. It should be not between Sumbawa and Lombok. It should be a little bit to the left, but neither here nor there. But there's Weber's line to the east, which is based on distribution of freshwater fish, and the transition from Asiatic to Papuan and Australian vectors is probably better correlated with Weber's line really than with Wallace's line, but at least in some parts of in the Malukus, there's a mixture of both groups. So one of the ways I'm noting that one can reduce transmission by members of this group is through community-based larval source management. Communities are good biologists. They know where to find larval habitats, and they'll work together to get rid of them if they know what to do. So there's some element of community mobilization that is possible. This is showing photographs of work that the government and UNICEF jointly supported in North Maluku on the island of Halmahera, showing drainage works, get rid of lagoons, open them up to the sea. You have to repeat this because they'll fill up again, but this can reduce breeding near villages and reduce transmission. Further east, this is on the border with Papua New Guinea. This is in Indonesia, but not far from the border. The young lady receiving a bed net has a nice Papua New Guinea Port Moresby t-shirt. I don't know if she was born in PNG or not. It didn't matter. The government of Indonesia was really good during this bed net campaign in Merauke. If you were living there, you got a bed net, by golly. But, and this is a young lady who's signing for her bed net, again in Merauke, during a bed net campaign. But as I said, and this is one of the good things about APMEN, programs learn from each other. In Myanmar, we know that village malaria workers putting pressure on transmission from humans to mosquitoes can reduce malaria transmission. We know this from Myanmar. So this has been rolled out by the government of Indonesia. This is in the time of coronavirus. You see hand washing stations, and you see the village malaria worker wearing a face mask, taking blood from a patient, screening. It says Cadre malaria on her bag, and they're putting pressure on the gameta sites now in lowland Papua, Indonesia. Here's another village malaria worker in Papua doing her job. So it's a case where the folks in Indonesia are learning from Myanmar, and actually I hope that the folks in the Mekong might take the possibility of larval source management a little bit more seriously, because I tend to see a division between the countries where larval source management was pioneered, i.e. in Indonesia and Malaysia, and the rest of Southeast Asia. India is another matter. India does a fair amount of larval source management, but I have not had the pleasure of working there. Okay, so conclusions. In elimination context, at least in Southeast Asia, economic forces that drive exposure, including forest resources, gold mining, farm huts, plantations. Plantations actually a piece of cake. You got an organization you can contact and you can deal with them. It's not a big deal. Seasonal brick making. We ran across people who are migrating due to seasonal variation in the price of fish. There's fruit harvesting season, durian, cashews, ganja. I guess that's not a fruit, but anyhow, they're seasonal crops that one has to go into the forest to harvest at particular times. The details of organization of each type of activity matter. Is there a supervisory structure? Is it legal, quasi-legal, illegal? Can the government approach, or an NGO, or the United Nations? Got to figure out what works. Malaria elimination in Asia hinges not only on what's going on in the Mekong, but in areas inhabited by anthropophilic members of the Anophelines feraltae complex. I once attended a conference in Chennai in India, and the former head of the malaria program in Sri Lanka gave a talk, and I remember his basic mantra, which was do the basics right: case management and vector control. And the challenges for malaria elimination, and Sri Lanka is a fine example, the challenges are not primarily technical, but managerial and political. And the basic thing to do is get subnational staff and communities proper support so they can think for themselves and they can eliminate malaria transmission in cooperation with central governments. Finally, since I know there are a lot of researchers here, my view is if vector control tools reduce transmission, albeit maybe imperfectly or only somewhat, get on with it and deploy it as long as costs are not too great. I doubt seriously we're going to get sufficient evidence for stringent evidence showing effectiveness in reducing transmission for tools that are targeting specific populations. So I would end by saying that I would echo the mantra of the former head of malaria control in Sri Lanka is do the basics right, but do it quickly, because the faster one acts for malaria transmission, the better off we'll be. Thank you very much.
So, thank you very much, Dr. Hawley, for very interesting and wise presentation, great overview, lots of things there to make one think about. I mean, one of the things that struck me is yet again, you know, that malaria, like dengue and other mosquito-borne diseases, it just strikes the poorest segment of society hardest. And it's the slice of society that is least able to deal with it. So, you know, if one could somehow raise the standard of living, this is wishful thinking, but quality of life, standard of living, so, you know, the types of households, time spent outdoors in early evening, so that those risk factors are reduced, you'd bring down. But, you know, economic development, that's a whole different ballgame as well. Bottom line is, it's the poorer segment of society that's affected. What I also thought I'd mention, because there are a lot of students here, both, sincere thank you, wonderful presentation from me and all the others, big clap of hands, great stuff, thank you. I should have done this right at the start, is to say forest-goers and residual malaria, just a reminder to our students participating in this presentation. Residual malaria, Jeffrey and others, correct me if I'm wrong, Bill, it's Indra, Rupam, is the malaria that remains, that fraction of malaria, once you've fully and optimally and thoroughly deployed you know, the known traditional tools for vector control or malaria control, such as the use of long-lasting insecticide bed nets, indoor residual spraying, and so on. You've done all that in the prescribed way, endorsed and supported and encouraged by WHO, and yet you have residual transmission. So, you know, by and large, countries across the world and endemic countries have done a great job in bludgeoning malaria from control phase to pre-elimination phase, by and large, through LLINs and IRS. But now we've reached that final mile. How do we bridge that final mile when LLINs and IRS are no longer sufficient to bridge that gap? This is our challenge. So, and you know, and that residual malaria differs sometimes across different geographic sites. By and large, it has to do with things like outdoor biting, early biting by some vectors, particular behaviors by particular groups, such as forest-goers, where they put themselves directly at risk because of the activities they engage in. So that's the whole point of this particular webinar, is to talk about that final mile. What are the causes of residual malaria, the contributory factors that make it a challenge, difficult to get rid of that final percentage before, so to reach elimination? And it requires a different mindset. We have to change our thinking. And as Bill pointed out, sometimes it has nothing to do about the particular tools, but a lot to do with program management and things like that. Basic funding, you know, it's all kinds of, but we need to start digging a bit deeper to understand what are the reasons that we cannot get rid of that final 10% or whatever it is. Enough from my side. I'm going to welcome and thank Dr. Jeffrey He, and ask Jeffrey if you can share screen and dive into your presentation, please, Jeffrey.
Hello, thanks Leo for the introduction, and I'm going to talk about, is my screen up? Can you see the screen?
Yes, wonderful, excellent.
And let me click onto full screen mode. Okay, So thank you, Leo, and for introducing this subject, residual transmission. And thanks to all participants wherever you are around the world, and for participating. And I will quickly start with a review. So a review of 150 publications that we took note of 6-7 years ago, showing that the Greater Mekong Subregion countries are reporting both vectors and non-vectors belonging to at least 5 complexes of morphologically indistinguishable species, thus reflecting the tremendous spatial heterogeneity in distribution patterns. Consequently, stratifying vector control becomes problematic, with the potential to be either cost ineffective, deploying control in non-receptive areas, or by not providing vector control in vulnerable populations in receptive areas. And I will come to this issue as highlighted by Thomas Burkott in his recent paper. Indeed, evidence from a variety of settings over the last half-century indicates that residual malaria parasite transmission occurs even with good access to and use of vector control, as pointed out by Leo a few minutes ago, as well as in situations where these interventions are not practical. This definition has recently been updated as follows, and I'm going to read here. Persistence of malaria transmission following the implementation in time and space of a widely effective malaria program. Thanks to Dr. Tessa Knox from WHO, the word residue is derived from the Latin name called residuum, meaning a remainder, that which is left behind, also as explained by Leo. And this is also shown in the top right panel by the piece of chocolate pie left behind after you eat the big chunk of it. So are we targeting the appropriate interventions at the right place and at the right time, especially in receptive and non-receptive areas, as stated in the study objective here? 2 recent papers have characterized the nature, the extent, and reasons for residual malaria and the particular challenges of forest-goers. The vector-borne disease environmental outline has featured our study, which is part of a larger TDR study in 10 countries and 4 WHO regions. The evidence of residual malaria transmission in Cambodia, plus an excellent review conducted by Liz Dunes, shows the importance of this issue in malaria elimination. And there are a few others again, which I will not, a few other publications which I will not go deeper into, but a review will come in shortly. And moving on, here we see the high ownership. Please look at the top panel and the lower half of the panel, which says that high ownership, access and use of bed nets among the village householders compared to forest and farm huts suggests inappropriate and cost ineffective targeting in these non-receptive areas of low transmission levels. The practice of carrying minimal gear when going to the forest, as shown in the middle lower panel, circled by the red circle, suggests that forest packs is a user-friendly accessory for forest goers when traveling long distances of up to 11 kilometers from their home origin in the village and return trip, mainly going to the receptive areas. And this was done through a GPS trackers. And this is already reported in the journal, in the papers that I showed to you. Now let's move forward. Similarities in mosquito biting frequency, as indicated in the second row, and access and use of bed nets human exposure to feeding among bed net users and non-users, and use of long clothing, repellents, untreated and treated hammock nets, see the bottom panel, offer the potential for public-private partnership opportunities to improve access to vector control products for forest goers who are at risk of malaria and other vector-borne diseases. Moving on the left panel are forest packs, such as the one deployed by the Cambodia National Malaria Program. These are user-friendly, they are light, and they can easily accommodate single bottles of topical repellent or mosquito coil, which are affordable. 2 cents per coil are shown here, and 80 cents per 50 ml tube repellent. Both products are registered in more than 50 countries. In this slide, we show the overlay of mosquito feeding times with day and nighttime activities of the forest rangers, who are the Ministry of Environment employees. And their self-reported repellent use in relation to times of high risk indicated by the red dots. And these red dots are pinpoint the duties and the activities of guarding forest by foot, starting in the morning from 10 to 12 p.m. and later on 4 to 5 p.m. and moving towards the evening, cooking and eating dinner from 5 to 6, followed by staying alert to deploy if necessary after 6 p.m. and moving forward, and then going to the dormancy sleeping time after 8:30. So this shows you the usage of repellents. Now, the key recommendations, the AC Johnson, another important key private sector in the Mekong, shows that there is strong evidence. Suggests that there are 3 key recommendations for repellent use, amongst which, on the third bullet point, showing that there is strong evidence that quality strategic BCC, behavioral change communication, can improve malaria prevention and treatment behaviors. For example, as progress is made towards malaria elimination, BCC can be used, for example, to reach populations who remain at risk as transmission dynamics change. For example, the mobile populations. And secondly, BCC can inform communities of the optimal timing of malaria control interventions. Moving forward, we notice that the long-lasting insecticidal hammock nets are distributed as part of a forest goer pack. The slide, previous slide showed you that forest pack, and these hammock nets can be put into the packs. And these are procured and distributed by the national program in Cambodia. There is a need to improve the targeting of these hammock nets, as commercial manufacturers, namely Vestergaard, Tianjin Yoku Trading, Fujian Yamei Industry, which have production facilities for WHO pre-qualified products in Asia Pacific, are not currently selling their products in retail outlets accessible to forest goers who need them. Whereas several commercial protection products are available in the Mekong countries, not all of these products meet the technical standards required for effective prevention. The most commonly commercial hammock nets, such as the one shown below here, are found in fast-moving consumer goods retail outlets near the forests in Cambodia, Laos, and Vietnam, and these are usually untreated hammock nets. We are currently mapping the supply chain indicated by the red circle in the top right panel as a possible venue for scale-up of bite prevention tools, and individually and as a part of the forest packs through both country, security, military, and their respective high-risk civilian populations. I look forward to your feedback with respect to different hammock options as well as mapping the distribution pathways in the hope of finding the source of the untreated product and hopefully identifying a way to swap it with a safer product or co-bundling with a treatment kit. There's also a need to acquire, various data sets, such as implementation quality, product field durability, medical anthropology to inform public-private partnerships. I'm going to quickly end my talk with a success story of a public-private partnership model from Sumbawa, Indonesia, which has strong similarities with Greater Mekong countries. Here is the location of Western Sumbawa, and the similarities are shown in most of these dot points, with the exception of no evidence of drug resistance to ACTs. And this combination of a workforce community control program requires a primary collaboration with the Ministry of Health in Indonesia, as well as the district health services. And underpinning the public health interventions are malaria, dengue control, TB, HIV, STI, health promotion, and more importantly, general public health services, which embraces things like water quality, food hygiene, and so on. And these programs were started in 1997, followed by an integrated workforce community program 2 years later on, and covering a population of 50,000 with community and with workforce under the employment of the mining consortium. And here's Sumbawa showing the key control activities on environmental management. For many of you who do not have a clear grasp of environmental management, this was started perhaps a century ago, where Indonesia has a long history of a successful environmental management through the pioneering work of Dr. Suelen Grebel, who used the species sanitation concept to do things like lagoon and stream channeling, algae control, and followed by larvicidin. And the evidence of impact through these private-public sector partnership resulted in a decline in slight positivity rate among malaria-infected school children in the mine-impacted communities. And you can look at the starting point. The baseline was 47 and declining down to 0 17 years later on, and supported by active case detection of disease burden after 10 years of monitoring, and again through the workflows, clinic passive case detection, and the accompanying metric of annual parasite incidents decline. So this is a jolly good show for a public-private partnership, which I believe can be replicated in various countries around the world, and we see that also in Africa and other parts of the world. Thank you for listening to me. All right. And hang on, sorry. So I forgot acknowledgements to the donor. This is a TDR supported program, and partners from various institutions and so on, and we including the Ministry of Public Health in Thailand, Cambodia, and Vietnam. Right, so I will now close up here and depart from the shore. How are we going to do this? All right, stop sharing. Okay.
Stop share panel. There we go.
Right.
Yeah. So, Dr. He, thank you so much for those insights. Just pointing out, key issues there. Inappropriate distribution of nets where they're not best made available. The high percentages of damaged nets, the availability of these forest packs. I, for one, would love to be able to buy a treated hammock I've asked my colleagues in Cambodia to look out for me, but those hammocks seem like an excellent idea for forest goers. But the availability of those forest packs sounds like a good thing. But again, you know, it's just, Jeffrey pointed out the issues around communities. Communities are at the face, direct, at the cold front of being exposed to infection. And I don't think, with respect, I don't think that we've properly engaged with communities and gained their support for self-help, as Bill pointed out. You know, larval source management, and Jeffrey pointing out about, you know, fixing and mending torn bed nets, etc. There's a lot more we can do to encourage community participation, self-help opportunities. But I'm not going to dwell on that. It was Jeffrey's talk. I thought it was an excellent presentation. Thank you, Jeffrey. But I would like to ask Jeffrey, in your question and answer session, may I ask you to address this question? As a, you know, much of the problem associated with residual malaria is the outdoor biting issue, and that stems partly from zoophilic behavior as well, where many of the vectors don't, like in Africa, where, you know, Funestus and Gambi are strongly attracted and feed preferentially on humans. In Asia Pacific, there are many species that transmit malaria, but they feed as readily, as easily on cattle or other animals as they do on humans. And that's a problem, because you can't attract them to a particular place, such as indoors, where you can then hit them with indoor spraying and bed nets, etc. So just your thoughts, given that so many of the vectors in Asia are zoophilic, or not zoophilic, but, you know, they feed as equally on humans as on cattle. What about the use of ivermectin or similar products, which have been shown in multiple experiments to have high effectiveness in killing mosquitoes that come and feed at them for 2 or even more weeks? And then the other thing I wanted to ask your opinion, Jeffrey, aside from the use of endecticides as a supplementary tool in village situations, or even in rubber plantations, etc., where you often do find cattle, but also for forest goers, the use of transfluthrin impregnated strips or bands that you can put around 4 trees, and, you know, you sling your hammock in the middle, or whatever. But the use of these impregnated bands that apparently have quite good use for repelling or protecting people inside that. So just those thoughts. I've spoken too much. I would like to ask Indra, Professor Vythilingam, if she would share screen and share her presentation and insights with us on Plasmodium knowlesi. Plasmodium knowlesi and forest goers, what's next? Professor Vythilingam is acknowledged as a global expert on the subject. We couldn't ask for somebody better to address us on that, so thank you, Indra.
Thank you, Leo. Good day, everyone. So I'll be talking on Plasmodium knowlesi and forest goers. What's next? Now, as you all know, Plasmodium knowlesi is a simian malaria parasite affecting humans in Southeast Asia. In Malaysia, in 2018, it has been the predominant species affecting humans. 89% of the cases were Plasmodium knowlesi. We had about 4,000 over cases of knowlesi, and there were no indigenous cases of human malaria. So as you all know, Malaysia is in the pipeline for malaria elimination. What about the other species? This is just a map to show you Southeast Asia, and the distribution of the Anopheles mosquitoes, the leucosphaerus group of mosquitoes, the malaria cases, and the macaques. So all the blue squares are to show that the knowlesi cases in other countries started after 2008. The red dots were the ones before 2008. So we know that now all countries in Southeast Asia have reported Plasmodium knowlesi cases except Timor-Leste. And we know that the leucosphaerus group of mosquitoes is picking up the parasites from long-tailed macaques, and this transmission is ongoing. Then now these mosquitoes are also biting human and transmitting it to human. But what we still do not know is that is human-to-human transmission by these mosquitoes taking place? This is something that we need to answer. Now, for all collections of mosquitoes in Malaysia, the best method is to use human landing catch for the Anopheles mosquitoes. And we were fortunate. From 2005 until 2008, we were allowed to use monkey-baited traps. So we set up platforms. We used to collect mosquitoes at ground level at 3 meters and at 6 meters. Now, actually, Plasmodium cyanomogae was the first simian malaria parasite to infect humans. But this was an accidental laboratory infection which took place in America. Don Iles and his co-workers were infected when they were dealing with infected mosquitoes in the laboratory. And as you all know, the first natural infection of Plasmodium knowlesi took place in an American surveyor who was working in the jungles of Pahang in 1965. So if we look at the history of the knowlesi vectors, Anopheles hackeri was first incriminated in the coastal areas of Selangor, and this species of mosquito was only biting monkeys. Then they found Anopheles latens to be the vector for Inuai, Introlatus to be vector for Cyanomogae, Fieldii, Crescens to be a vector for Cyanomogae. So since this hackeri was only biting the monkeys, was not coming to bite humans, so at that time they said that simian malaria would remain with the monkeys. But after 2004, the landmark paper, as you all know, so we started our work on the vectors from 2005 onwards. So we have incriminated Anopheles latens in Kapit, Sarawak, Anopheles crescens in Kuala Lipis in Pahang, Introlatus in Ulu Selangor. We're still doing now a lot of work in Peninsular Malaysia. And in Sabah, Anopheles balabacensis has been incriminated. And a lot of work has been done in Sabah. Now, I have summarized the studies here. So you will see that whenever we did longitudinal studies, we always worked in the farm, the forest, and in the village. So in the farm and forest, all 3 vectors are found. And in the village, Anopheles latens is found in very small numbers. We could hardly find Anopheles crescens. The only species that is found in all 3 places is Anopheles balabacensis. And balabacensis is really an efficient vector. Now, if we look at the biting time of these 3 predominant species, they all are biting outdoors and in the early part of the night. They start from between 6 onwards. So by 6 to 9, we get the peak biting time of these mosquitoes. And what happens? In the monkey bait trap, these 2 vectors, latens and crescens, they were found biting the monkeys in greater numbers between 9 and 1 a.m., 9 p.m. and 1 a.m., and they were biting more at 3 meters and at 6 meters. So that is the sign that the periodicity of the gametocyte state coincides with the biting time of the mosquitoes. So once these mosquitoes have picked up the gametocytes, when they become infected with sporozoite, it's so nice. They come down and bite the human when they are outdoors, not protected. And the sporozoite rates, we have found them for all 3 species in the farm and forest, and only in the village, only Anopheles balabacensis has been found to be positive. Now, a case control study was done by Menin and co-workers in Sabah, where they did collection in case and control houses. And as you can see from the results, indoor collection is very minimal. 95% of the mosquitoes are collected outdoors, balabacensis. And of course, the collection in cases case area has been higher and significantly different from the control area. That we have so far, we find that Plasmodium, cynomolgi, and inui are found in larger numbers in mosquitoes compared to knowlesi. And also these mosquitoes carry mixed species of the parasite. Very rare you find a single Plasmodium to be present. And similarly, a similar thing was found in Vietnam by Meno and co-workers, where they found Anopheles dirus to be positive, and it was more cynomolgi, inui, and kutnii was found in greater numbers than knowlesi. Now, if we look at the results of macaque surveys that have carried out, in Sarawak, inui was predominant in the macaque, followed by knowlesi and kutnii. And in Selangor, in Peninsular Malaysia, we found inui to be predominant, followed by knowlesi and cynomolgi. These are the long-tailed macaques. And also a study that was done by Zhang and co-workers in Southeast Asia also found cynomolgi to be predominant. Now, the first case of naturally acquired cynomolgi was reported in Peninsular Malaysia in 2014. So since then, there has been reports recently of asymptomatic case of Plasmodium cynomolgi in Cambodia. There have been cases reported in Sarawak, Malaysian Borneo, as well as in Sabah, Malaysian Borneo. And you know that Southeast Asia is the hub for Plasmodium knowlesi. We are one thing not selfish. We have exported these parasites to various parts of the world. Okay, as far as USA, as well as to Europe, to Australia and New Zealand. Now, recently, a Danish visitor who was visiting Malaysia and Thailand brought a parasite back to Denmark. He fell ill, and they found out that he was actually suffering from, he was actually down with Plasmodium cynomolgi. Now we know that with deforestation, changing of landscape, the macaques have moved from deep forests to forest fringes and farms, and the mosquitoes have followed them. So when humans move from villages to farms and forests, they get infected by these mosquitoes. Now, in conclusion, with malaria elimination, humans become less immune to malaria, thus become more susceptible to PK as well as to other simian malaria. And we have showed that macaques are infected with inui and cynomolgi. Mosquitoes are also infected in larger numbers with inui and cynomolgi. The mosquitoes are biting early outdoors, so in fact, indoor residual spraying and ITNs will not be effective. So it is pertinent to screen people living in high-risk areas, not just for PK, but also for other simian malaria as well. And we should remember that Plasmodium falciparum and vivax at one time was affecting non-human primates, and it jumped host about 50,000 years ago. So now, when we are eliminating human malaria, we need to be prepared. So we need new tools to control the vectors as well as to detect the parasites in humans. We should have RDTs to be able to detect the different simian malaria parasites in humans. So with that, I would like to acknowledge all my students and staff who have worked with me from 2005 onwards. And now we have a huge grant starting in 2019 until 22 to work in Peninsular Malaysia. So we hope that we will get more work coming up from Peninsular Malaysia. And we have had grants from the Ministry of Health, the Ministry of Education, as well as we worked along with the London School of Hygiene and Tropical Medicine. So with that, I would like to thank you all. Thank you.
Professor Vythilingam, thank you so much. Absolutely fascinating presentation. You know, when you start talking about 8,000 cases per annum, that's no longer a curiosity or an anomaly. Malaysia is close to achieving elimination of falciparum and vivax. So your problem is going to be knowlesi, and you're hit by a double whammy that it looks like from your presentation. Much of the transmission occurs outdoors. And of course, it's a zoonotic infection. So, you know, you can do your best by clearing parasites and addressing, you know, the simian malaria in humans, but the reservoir is out there, out of reach in the forests. So that presents a very serious, real challenge. Thank you for making us more sensitive and aware to the challenges that lie ahead and the risks. You pointed out, you know, falciparum vivax have a primate origin historically. There's now cynomolgi, knowlesi, and others lurking on the horizon. They complicate issues. Very interesting presentation. Thank you so much, Indra. We appreciate it. So there are questions building up. Knowledge and wisdom does not reside exclusively within the panelists. So I want to encourage, where there are people within the audience that have answers or opinions, please post them in response to some of the questions that may be arising that you feel you would like to address. It's free for all. Please go ahead and respond to those questions. So our next presentation is from Dr. Rupam Tripura, who is a member of the highly respected Moru group of people that publish regularly top quality publications on malaria in Southeast Asia. And we look forward to you know, what you're going to be telling us, Rupam. Thank you so much for being with us. Thank you so much. You can share screen. Excellent.
So good afternoon. Thank you very much for joining. Today I'm going to present an ongoing prophylaxis trial that we are conducting in northeastern Cambodia. This project will be implemented by Mahidol-Oxford Research Unit together with National Malaria Control Program and the local partners. And of course, this project is funded by Global Fund Right to Grant and sponsored by University of Oxford. So just briefly about the background and the rationale of this project. Cambodia has a goal to eliminate falciparum malaria by 2020 and vivax malaria by 2025. If we look at the latest data in this graph, we can see that the incidence of both falciparum and vivax cases decreased significantly, particularly during 2019 and 2020 in compared to previous years. This is mainly due to intensive intervention took place following reports of multi-drug resistance, falciparum malaria. So it was attempt to contain the drug-resistant falciparum malaria. So the interventions include strengthening the village malaria workers network, deploying mobile malaria workers to test and treat forest-goers, and widespread distribution of insecticide-treated bed nets, focus screening and treatment around the clinical case, mass screening and treatment in the hotspot. So these all lead to this historic low decrease in incidence. But of course, malaria transmission is now only related to the forest-goers. But the problem, as you have heard from the previous presentations, is that preventing infections in the forest workers is a major challenge because of exposure to the Anophelines vectors, particularly Anopheles diarrhea, which tend to bite outdoors in daytime. So what we think is the testing and treating forest goers by mobile malaria workers and current preventive measures like distribution of insecticide treated hammock net or bed net will not be enough to reach the elimination goal. We think that chemo prophylaxis could play a role to protect the forest malaria. So the aim of our project is to assess the efficacy of intermalaria prophylaxis for forest-goers and to determine the acceptability and feasibility of implementing a prophylaxis trial to better understand the epidemiology of forest malaria. And of course, the ultimate goal will be to identify the optimal package of interventions against forest malaria. There are 3 components. First component is the prophylaxis trial, where participants will receive either artemether lumefantrine or multivitamin. We also intend to do the understand the forest epidemiology by GPS mapping of tracks, forest camps, and villages. And in the qualitative research part, we will conduct interviews of forest growers, health workers, and policymakers to understand their view on idea of prophylaxis. So the target is to recruit 4,400 participants episode. One episode consists of 28 to 35 days, and a participant can join maximum 3 episodes if they go to forest. They continues to visit forest. The participant in each episode will do the interview and will collect some blood sample to test for malaria by UPCR. If a participant stops forest visit, we will provide a 28 days post-forest prophylaxis. We intend to recruit adults 16 to 65 years who plan to travel forest within next 3 days and stay overnight. Of course, they need to have willingness and ability to comply with the protocol procedures. We exclude pregnant and breastfeeding participants and those who get malaria treatment with ACT in the past 7 days, severe vomiting or diarrhea, and those who have seen signs symptoms of clinical malaria confirmed by RDT at the time of screening. So eligible participants will be randomized to either artemether lumefantrine or multivitamin arm. They will get drugs twice daily for first 3 days, then followed by twice 1 day per week. We will provide biscuits containing fat to take with each dose of drug. So this is the, you can see the yellow spot. This is the study site. This is located in the Siampang district in northeastern part of Cambodia, which is bordering with southern part of Laos. This is one of the malaria hotspot in Cambodia. So as you know, that engaging the forest growers is always a bit of challenge. So what we did is that we wanted to involve the local authorities like governor office, provincial health department officials, and also local health center staff, village leaders, and together with the community health workers like village malaria workers, mobile malaria workers to reach out the forest growers. Particularly, we want to organize meetings. We want to organize the community meetings where villagers will be invited, where we intend to provide the information on project activities, aim and objectives, and we describe the eligibility to participate, and we will describe the possible benefit and harm while joining the project. And at the same time, village malaria workers will be actually the focal contact point for the forest growers, who will contact them to the village malaria workers first before contacting to the trial staff who will run the trial for enrollment. So the trial we started in mid-March 2020. So far, we assessed for eligibility of 322 participants, and 91% were randomized to treatment. Unfortunately, we had to exclude 9% participants, although we thought that most of the people will be healthy individuals, those who are able to go to forest. So among excluded participants, most participants are female, around 65%. The challenges is that they are either pregnant or plan to be pregnant. That means that they cannot guarantee that they will not be pregnant while they join the trial. If you look at the participant, the median age of the participant in artificial lumefantrine arm is 28 years, and multivitamin arm is 38 years. And we also got a considerable number of female, 21.2% among enrolled participants. Among all enrolled participants, 144 participants had completed first episode, that means day 28 to 35 period, and 91% of them actually continued taking prophylaxis. Unfortunately, 5 females were pregnant, and 5 participants as of the forest visit, that means they got the Forest-goers prophylaxis for next 28 days. And only 1 person withdrawn consent after 28 days that he did not want to continue taking the drug. 1 participant missed visit. So we also looked at adverse events, although you know the artemether lumefantrine is a very safe drug used by millions of people. But in compared to multiple, what we found is that 21.7% who came for follow-up actually said that they had adverse event, and as we can see that there are no difference between 2 treatment arms. Most frequent adverse events are headache, dizziness, fatigue, and abdominal pain. I can say there was no difference to at this stage of recruitment. So as per protocol, we also reported serious adverse event, 2 accidental injuries in multivitamin arm, which is hospital observation. And actually both participants resumed the drug intake after recovery. The challenges and lessons learned so far at this stage of recruitment is that prophylaxis among healthy individuals was a new idea in the community. Involvement of local authority and community health workers was actually vital for this trial to engage forest-goers. We had to spend adequate time for explanations through meetings to disseminate positive information. It also gave villagers, community leaders an opportunity to discuss their concerns and provide advice. As I said before, recruitment of female participants was a challenge. We had to exclude a considerable number of female participants, and 5 participants who came for follow-up 20 to 35 were pregnant. So drug administration schedule, 3 participants could not follow the drug administration schedule as advised. And one of the thing that because this is a community-based project, we are seeing also the impact even in the remote areas. This is COVID-19, as you all know. So even though there was not a single positive case in this province, but still panic situation is there inside the community. Villagers were suspicious on strangers visiting their places, and recruitment was paused for almost a month. Then until situation improved and local authorities permitted to start. So we should not draw conclusions at this stage of recruitment, but so far what we have seen is that weekly artemether lumefantrine has been safe. Adherence to the trial drug was actually satisfactory. Only 1 person did not want to continue drug intake after 28 days of enrollment. To avoid the mistake by the participants, simplified drug dose and schedule is essential for a prophylaxis trial. And while designing intervention, we need to consider how to meet the challenges recruiting female participants. Although we may think that only males they go to the forest, actually a significant proportion of females they also go to forest or work in the farm surrounding the forest. So for us, careful explanation was needed, particularly to use contraceptive methods. Particularly, we encourage condom to be used. So this is all from my side. Thank you very much.
So, Dr. Tripura, a great thank you for sharing those results with us. You can stop sharing screen now. But sincere thanks for that. You know, I have great respect for your group there at Moru. You've come up with some truly interesting findings reflected in a series of publications. There was one about 2 years ago, I remember reading last year. You know, that just captured what we should be doing for addressing residual malaria by looking at the parasite component, not just hammering away at the vector component, but trying to deal with the residual parasitemia and infection taking place, transmission interruption. So, you know, I think, you know, how do you eat an elephant? One bite at a time. And I think that's with the residual malaria as well. Perhaps what we should be doing is targeting some key hotspot residual malaria areas that are well defined, where we can bring to bear an integrated, holistic package of interventions that deal with vector control, parasite control, community behavior change, and sorry, I've done something wrong here. So we get that integrated approach, and it includes seasonal chemo prevention. It probably includes also maybe periodic primaquine for gametocyte clearance. WHO has endorsed 0.25 milligrams per kilogram, which is acceptable, and it bypasses the risk posed by G6PD. So anyway, I think, you know, you're onto something there, that we should be looking at all these different aspects that nail not just vectors, but start homing in on parasite control as well. So that concludes our presentation. We're now going to move into the question and answer session. I'm going to put this up for a little while so that you can write down those websites in case you want to have a look at or recommend the recorded session of those presentations. And I'm also going to ask our presenters if you can all put your video on so that the audience can see you, because we're now going to move to questions and answers. I don't know where to find questions and answers here. May I also ask, right at the end of questions and answers, there's a little poll, and I want to ask you, please, do us a favor. It'll take you less than 1 minute. It's about 5 questions or so, and it's multiple choice type questions. You know, you just click the appropriate block. But it will help us understand what we did right, what we can improve on, what we got wrong, just so that next time we hold a webinar, we can improve on the webinar. So I'm going to ask Jeffrey, Dr. He, I asked you a couple of questions relating to transfluthrin and endectocides such as ivermectin in cattle. While I look at the other questions, maybe you wouldn't mind just sharing, if you have any thoughts on those aspects, maybe share them with us to start the ball rolling. Jeffrey, if you don't mind.
Okay, so your first question was about the efficacy of transfluthrin and its potential for people going to the forest. there's a special chemistry about this volatile airborne chemical. We are always conscious about the efficacy of these things when it works quite perfectly well in indoor situations. However, when you take it out to open air plantations or forested sites, where there is perhaps a slight movement of wind or convection currents, then you burst the bubble, the air bubble, so to speak, and hence there's a lot of things we do not understand yet about transfer train and its application for outdoor spaces. That's where I draw the line there. Regarding endectocides, things like ivermectin administered to cattle and other domestic animals, particularly cattle. I question even the residual toxicity of these things. Although it works quite perfectly well in laboratory settings regarding the killing effect of these drugs, we still do not understand whether the formulation that is administered to animals would cover the period of transmission, the highest transmission in the ecological setting, which means that if the half-life of that drug is a few weeks, maybe we can get a good effect in that period of time, which is less than the whole transmission, the whole transmission season. So this is where I draw the line again regarding endectocides. Somebody may correct me on my false assumptions there. Thank you.
Thank you for that, Jeffrey. Yeah, my understanding is that typically you can expect ivermectin in cattle administered at a particular dose that has the side benefit of being an anthelmintic as well. It kills the internal helminths, internal flatworms, roundworms, and so on. So there's that positive spin-off for the owners of the cattle. But at that particular dose, it can be expected to kill mosquitoes that feed on the cattle for typically about 2 weeks. And that is, and I mean, cattle attract large numbers of mosquitoes. So you're reaching large numbers of, what you're also doing is you're influencing the population of mosquitoes and probably selectively killing off those mosquitoes, female mosquitoes that are carrying sporozoites. And it's a younger, newer generation of mosquitoes that keeps emerging because you're now selectively hammering away at the dangerous mosquitoes. So you're skewing the mosquito population in a favorable way as well. But anyway, as you say, there's still lots of interesting work to be done. So I have a question here, Jeffrey. It seems to be at you as well. I'm going to try and find questions that we can direct at our other speakers as well. But
Leo, forgive me. I have been going through the questions. I've answered quite a number of the ones that directed at me. There was a general question, though, that I inadvertently clicked answer live that was liked by a number of people that I think we should address briefly, and I would like to hear the thoughts of others. But it was, what impact has COVID had on malaria elimination and control activities? So I clicked answer live and it disappeared. And I don't want people to feel like they've asked a question and they're being ignored.
Yeah,
so
very good point.
I would just briefly like to note that at least the experience that I have, the impact of COVID has been twofold. One is it adds an additional logistical layer to get personal protective equipment, face masks, to health workers. That's proven to be a challenge. And finding funding for this has been difficult for different countries under different circumstances. And then the other thing that has occurred in a few places is it's introduced an element of fear, both on the part of communities and on the part of health workers, such that treatment, diagnosis and treatment services have been affected. So it's had a deleterious impact. One of them, the PPE, I think is solvable with money and logistics. The other, the element of fear, I think is probably solvable by figuring out how to reduce transmission of this thing. Over. Thank you.
Yeah, no, good point. I also happened to see that question before it disappeared. And of course, this is a hot...
It disappeared, I'm sorry.
No, no, you did the right thing, don't worry. So you try to respond, which is the right thing to do. So we appreciate that. But of course, it's a hot topic and it's relevant across the globe in all countries where malaria and dengue, etc., are public health challenges. And implementation of interventions is affected by COVID-19 restrictions on movement and social distancing and so on. So Indra, I'm not sure if you have any short comment on COVID-19, any observations you'd like to make, and then I'm going to ask Rupam, same question. You can be very brief. Indra?
We have obstruction in our own field that we are not able to carry out.
Indra, we can't hear you. Would you mind leaning closer to the computer? Thank you.
COVID-19 outbreak, we have stopped our field work. So it has taken back, our research has gone back a few steps.
Yeah.
But I think on the whole, it will definitely have some impact on malaria.
Absolutely, yeah. Rupam, any comments?
Yes, so that's what we are also following as we are working in the community, how COVID-19 could affect our work, affect our work, and also in Cambodia. So far, we did not see any effect because in Cambodia now the number is almost 0. So people are actually getting a bit beginning to get back their normal life, particularly in remote areas. So that's why we did not understand the impact like other countries that they have. Of course, if there are cases, it will have an effect because it's a kind of things. It causes panic to everybody, even we don't see the cases.
Yeah.
It will be difficult. Sometimes participants, because of the blockade, lockdown or the blockade, participants will be may have difficult to get access to the treatment. And one more thing is that actually COVID-19 situation caught off guard of most of the people, including the health workers. What I have seen is that during the time of situation, actually village malaria workers or health workers, they did not have any protective equipment. Not only them, and also the health centers in the remote areas. But luckily there was not no cases. That's why the situation was under control.
Yeah.
But difficult to guess.
Yeah, no, all good points, Rupam. These are very real challenges, but I have great respect for the way most countries, I think, have leaned backwards to try and continue implementing malaria control and dengue control activities despite all these challenges, and by and large have been successful somehow in maintaining some level of interventions, but in some cases it's not possible. So fully agree with you. There's another question. I'm going to try and weave together a couple of questions. There's one here from Michael McDonald, and it overlaps with another question from another gentleman about, and it's addressed to Jeffrey. Please speak to the topical repellent trial in Myanmar. I'm not sure if you'd like to respond to that question, if you're familiar with that particular study. But it overlaps with another question somebody asked. What about the use of repellent impregnated socks and other items of clothing? Maybe just a couple of words on that, please, Jeffrey. Use of repellent materials, whether topical or impregnated in items of clothing.
I think that study that Michael referred was done in Myanmar a couple of years ago. And it was distributed by...
Sorry, Jeffrey. There's an answer here from Dr. Winhan Wu, who may be one of the investigators. And right. I think this was done by Myanmar in collaboration with the Burnett Institute, I think, in Australia.
That's
and
the one.
I think the paper's coming out soon. And I've heard rumors. I don't know that it showed impact of repellents on malaria in some form or another, but I haven't seen the paper. So, but I've heard that in contrast to earlier trial that was done at a village-based randomization in Cambodia, that this one may have shown impact.
Yeah, correct, Bill. This was distributed by the VHVs, village health volunteers, in the villages throughout the transmission season, and the paper was delivered at the World Malaria Congress in Melbourne in 2018, and we first heard that the preliminary assessment showed that it was through a randomized control trial was quite effective. Yeah.
Yeah, thank you. I mean, there's it's a mix of questions, but also comments and suggestions.
Leo, I would just note that the news about showing some efficacy of repellents is good, because repellents, unlike some of the other products that are new and haven't gone through a PQ process, repellents are registered in many countries, and ministries can buy the things, and we can get on with it and use them. Whereas some of the other products that are in the pipeline, they've got to go through this arduous PQ process, and it becomes an issue. Do we wait for PQ to be completed, or does a national government that is independent of funding from the Global Fund go ahead and buy the stuff themselves?
Yeah. So, Bill, Jeffrey, help me out here, because I'm not that familiar with WHO requirements, etc. But WHO, as I recall, it doesn't actually recommend, I may be wrong, the use of repellents, because it's not a core intervention. But, it has application, for example, within forest workers. So would you recommend that more attention be given to this aspect of, supplementary measures to protect people like forest workers? Any thoughts on that?
If you have followed the VCAG, the Vector Control Advisory Group that WHO facilitates or brings its experts every year to give an independent assessment of potentially PQ type of products, the bottom line is WHO still insists on epidemiological impact type of studies, whether through individual or group or cluster randomization. And this has been done in more than, I believe it's at least 2 countries, and covering at least 1 or 2 transmission seasons. So, so when we do this type of repellent studies, or planning to do these repellent trials in countries where the disease burden is low, and it's almost impossible to recruit sufficient numbers to do this kind of studies. So this is where it's hanging at this point in time. So nevertheless, as Bill pointed out, countries and programs are free to buy these things for individual or self-protection.
Yeah, thank you. So, Rupam, there's a question here. Specifically, what is the Artemether lumefantrine resistance status in your study area in Cambodia? I'd like to broaden it. You know, what is the, resistance to artemisinin is pretty widespread in all countries of GMS. And there's the threat, of course, of it spreading to Africa. That's what everybody is scared of. And that's why there's pressure on trying to eliminate at least falciparum malaria in GMS, which is the core of the resistance against artemisinin-based therapies. Was there resistance in your study area, and in the bigger picture of things, speculating, are we going to win the war? Are we going to kill off falciparum before resistance jumps to Africa? Just speculate for a moment. Your thoughts.
So in terms of artemether lumefantrine, what happened, there was one trial that was conducted in Cambodia around 2012, where they actually found the efficacy of artemether lumefantrine was around 82 to 82%. But the problem of that study was because they did not provide the fatty food to the participants when they did the recruitment. Since then, there was no trial was conducted related to artemether lumefantrine. But recently, we also did a trial regarding the triple artemisinin therapy versus artemisinin-based combination therapy. That is artemether lumefantrine amidoaquine versus artemether lumefantrine. So we just finished the trial. We recruited around 250 participants, and we hope to get the results soon. So at this stage, we actually cannot say that there is a prevalence of artemether lumefantrine resistance, because only one study was done a long time ago, which they did not even use the fatty food. And another thing is, we also did targeted a malaria elimination trial. It is called mass drug administration, where we used a dihydroartemisinin piperacin. You know that dihydroartemisinin piperacin has got around 60% 60% failure rate. So what happened when we did the mass drug administration trial? Actually, it was effective against the asymptomatic parasite positive individuals. That means those individuals were positive by PCR, but they did not have any symptoms in the mass drug administration trial. So we think that when the parasite number is very low among the healthy individuals, that drug will work. So we are not worried about that. And of course, for the clinical cases, we need to look at the data, our data, that we just completed the trial. And results of that trial will actually come soon. Tom Peter and my Tom Peter and Professor Aryan is the principal investigators of that. And of course, maybe in a couple of months, we can share the data of efficacy of artemether lumefantrine and also triple therapy.
Sure. Thank you so much, Rupam. I'm going through the questions. I'm trying to find one for Indra. I'm struggling to find one, Indra. But if you see one that you'd like to respond to, please
I'd like to ask Indra a question.
Okay, please.
How is Malaysia going to eliminate this parasite from Sabah and Sarawak? I thought I had heard that there was some effort to use outdoor spraying or something. I'm not sure how to deal with it. I'd like to know what Malaysia is aiming to do. Thank you. You have to unmute yourself, Professor. I'm not sure she heard me, Leo.
Indra, did you hear the question?
You're muted.
You need to unmute yourself, Indra. There we go.
What's the question?
Yeah, the question was, what is Malaysia doing to try to eliminate human infections with Plasmodium knowlesi, or at least reduce them?
One thing what we do is that we do look for them out in the sense that the blood samples are always tested done PCR to make sure that we separate the Falciparum morbivax from knowlesi and the other simian malaria parasites. So in most cases, PCR is carried out. And they do put up signs. There are a lot of signages in Sabah informing people that when they go to certain areas that that place is in fact infested with Plasmodium knowlesi.
Okay, but in terms of interventions specifically targeting knowlesi, are there any?
They try to give clothings which are treated, but I think it has not really taken off to any great levels. And there was a recent paper that they're trying to work on outdoor residual spraying, but I do not know how effective that is going to be, because most of the infection is actually taking place either in the farms or in the forest, not so much around the villages.
Okay, thank you.
Okay, so we've been going for quite some time now, and I think we need to, in fairness, wrap it up. It's been a very, very interesting webinar, and thank you to our top quality presenters for your time, commitment, sharing your time, experience, insights, knowledge, etc. We will be synthesizing, collating all the questions and asking our presenters if they would mind trying to answer at least some of those questions. We'll send them to you if you don't mind having a look at them, respond briefly to some of them if you don't mind. What we're also going to do is there was a question here, somebody wanted access to Dr. Indra's slide. So as I mentioned, we're going to put the full webinar on the APMEN website, APMEN OREN. Tin did put it in one of the chat boxes. We'll also put the slide up now again to show you that website. And I'd like to ask participants, please to go to that polls. How do we deal with that? You just click on the polls at the bottom, around about the middle of your screen at the bottom. There's polls, or Chris has kindly put it up there for us. If you wouldn't mind responding to that, our audience, thank you so much. So to everybody listening in now, genuine, sincere, thank you for your time. Bill, Jeffrey, Indra, Rupam, my deepest gratitude to you. Thank you so very much indeed. Until next time, all the best. We'll try and hold another webinar in about 6 weeks' time.
Thank you too, and thank you all.
Thank you.
Have a nice day.